Hello, and thank you for joining us today for our presentation, CNL's Collaborating During Turbulent Times. My name is Bonnie Hopt, and I'll be presenting today with Kelly Drumright, Amber Grubb, and James Key. We have no disclosures. Today we're going to discuss some key concepts for developing a community of practice call. We're also going to identify some strategies that promote team collaboration, and we're going to share some of the best practices that were developed by our CNLs and disseminated to our other facilities. So our journey began in 2020 at the CNL Summit in San Antonio. A group of CNLs from Tennessee and Kentucky met, and we identified that there was a gap in collaboration between the CNLs at our facilities. So the team established the VISN 9 Clinical Nurse Leader Community of Practice Call. And what we did was we reached out to all of the clinical nurse leaders in our VISN at our sites, established a mail group, a SharePoint, and it was decided that we would have monthly meetings. And during these monthly meetings, we would share best practices and also our challenges, any challenges we were having in our sites, so that we could collaborate and identify gaps. And from this, the teams really work hard at improving processes and outcomes for our veterans and the staff. Of course, this meeting was built with the high reliability mission in mind, and we really focus on safety, continuous process improvement, and our team collaboration. And now James is going to present to you COVID code best practices.
Bonnie. My name is James Key, and I am from the Rob Blair Rex VA Medical Center in Louisville, Kentucky. And I'm going to talk to you all today about best practices during COVID for code blue and resuscitation events. Now, during the start of the pandemic, everyone was worried about getting infected with COVID during CPR and resuscitation. So here at this facility, we ended up treating every patient as if they were COVID positive during a resuscitation event, just because we didn't know. We didn't know what was going on at the time. But since then, we have been testing every patient that comes to the emergency department, and then we get the results. If it comes back negative and we do CPR, we do it just like normal, just with our surgical masks on. But if the patient is positive, or if we don't have the results back and they code, then we are treating them as COVID positive, meaning we would need to gown up with our PAPRs or N95s and goggles, our gowns, our gloves, and the whatnot. And for this, one of the big things was limiting the amount of patients and people who come into the room. The big thing for most of you all, you probably have a lot of people that come to the codes if a code blue is called. Well, in this case, we tried to limit that to 2 nurses, 1 respiratory therapist, an anesthesiologist, and an ED physician. We've since gotten rid of that anesthesiologist coming, and instead it's just the ED physician, 2 nurses, and an RT inside the room. There's other people outside the room, but these are who's inside. Now, once that patient is intubated, we don't want to break the circuit. So we actually have a second respiratory therapist bringing a ventilator so that they can hook that up right away. Now, one of the biggest challenges that we faced was communication. With the negative pressure rooms, it was very difficult. So we trialed walkie-talkies and baby monitors, and we found that the walkie-talkies work the best. So we've actually now put those on every single crash cart in the facility. Another thing during a code, if they needed a central line, it was hard to get that done to get another person into the room. So we've put IO kits on every crash cart. Our hospital and our VISN have purchased Lucas 3 compression devices, and we have now got 3 of those in our facility to use during codes. And this has decreased the amount of people inside the room. It's helped with our CPR depth, rate, and recoil, which has greatly improved our CPR outcomes in the last 3 to 4 months. To get everyone familiar with this situation, we did a lot of mock codes and simulations. And this really helped our nurses, our doctors, and our respiratory therapists get comfortable with the situation and know what to do, which has helped our outcomes over the course of the pandemic. I'm now going to turn it over to Amber to talk about PPE. Thank you.
Hi, I'm Amber Grebb from the James H. Quillen VA Medical Center at Mountain Home, Tennessee. During COVID-19 pandemic, it has led us to use the various forms of PPE in multiple combinations to care for our COVID patient population. Unfortunately, determining the proper PPE needed in each situation, while critical to ensure the highest level of patient safety and staff safety, was very confusing for our staff. Not to mention, we were trying to preserve scarce resources in regards to our PPE. So what we did about it is we created a standardized color-coded PPE kit in large Ziploc bags. We had multiple kits to account for multiple scenarios. We determined the PAR levels for these kits and a process for restocking on the units that took care of COVID patients. We also assigned specific employees that we pulled from other areas that may have seen a decrease in their patient load or appointment load. And we utilized those employees to help support our PPE kit stocking. So those employees would go into a specific area and stock the kits with what we needed and then come and stock them to the unit. We also educated the staff on which kits to use in each situation. These kits have been changed and modified as COVID has progressed, and we have had changes in our PPE. As a result, we have seen that the staff have readily available PPE that is clearly identifiable, so they know which kit to pull for which situation and aren't scrambling around trying to find various pieces and parts. This has decreased our PPE waste. It's also decreased our delays in care and eliminated staff confusion, but most importantly, it has increased our safety for both our patients and our staff. Where are we now? We have shared this process on a VISN 9 CNL community of practice call. Several other facilities have inquired further about our process and are looking to replicate this process at their facility. We now have 2 hired FTEs that are temporarily assigned to support this process, with additional personnel that can be pulled if needed to assist. And now Kelly is going to talk to you about standardized nursing documentation across the VA.
Thanks, Amber. This is Kelly Drumright, and I'm from the Tennessee Valley Healthcare System in Nashville, Tennessee. I'm going to briefly talk to you about how we work together to standardize nursing documentation across the VA, as we have all purchased a new system of Cerner, and that is going to be applied across the VA and the Department of Defense. And with that became an opportunity to standardize documentations and tools across all of our facilities. So this goes in line with the high reliability, as Bonnie spoke to earlier, and this using the same tools and documentation helps us decrease variability. It improves the ability to capture relevant data for measurement of patient outcomes using reliable and valid tools for data sources. Next slide, please. And now this is a major change for anyone who's worked in the VA before, as we all use different methods of doing these things in the past, and a lot of us like to free text things, so massive change. We can go to the next slide. All new tools, assessments, SOPs to guide what we were going to chart. You can go to the next slide, please. And how did we help navigate these challenges and concerns and anguish from staff? Because there's definitely was an increased learning burden and a documentation burden that went with it. So we got together and we collectively got our concerns put together and questions that we had, and we helped navigate these challenges by creating implementation strategies and educations we could share amongst each other, and issues that we could not resolve amongst ourselves, we put together and submitted it to the national level to help us understand or get our things resolved. Going forward, this will not go away anytime soon. It's a multi-year rollout across all the VA and Department of Defense. So I'm sure we will be navigating challenges as notes are updated, new tools are put into place, and standard operating protocols that go with it go forward. So we don't see that we won't be friends in navigating this together going away anytime soon. Next, Bonnie is going to wrap us up.
Thank you, Kelly. And now I'm going to take a brief moment to share with you our clinical nurse leader end of the year poll. And as you can see, that the team strongly agrees with the overall satisfaction of the call and the meeting experiences. Some of the qualitative feedback, as you can see here, I'll just read the first one that the team shared with us is, I feel these calls are very helpful in building network connections and facilitates the sharing of information and processes. So in conclusion, we've definitely demonstrated collaboration between the clinical nurse leaders in Kentucky and in Tennessee. We've shared best practices which have really improved outcomes for our veterans and staff across VISN 9. And we were actually innovative. Even before COVID, we set up these calls and established our virtual community. Again, thank you for joining us. Here is our contact information if you need to reach out to us.